Good afternoon. Welcome to today's presentation, State of the County, a panel discussion with local leaders about the effects of substance use disorder in St. Clair County. This webinar series is made possible by a grant award from SAMHSA, the Substance Abuse and Mental Health Services Administration. We're excited to provide this virtual series during the month of September, which is National Recovery Month. Today's session is being recorded and will be uploaded to the CMH YouTube channel. Today, our panel of professionals will discuss what their organization is doing to combat substance use within St. Clair County. Please use the chat feature at the bottom of your screen to send your questions to our panelists. You can indicate if you choose to pose them to a specific person or to the group as a whole. Our presenters today are Matt King, St. Clair County Sheriff, Jim Johnson, Chief Executive Officer, Region 10 PIHP, Deb Johnson, Executive Director at St. Clair County Community Mental Health, Ken Hubelman, Clinical Coordinator and Outpatient Therapist with Fort Huron Odyssey House, and Dr. Annette Mercantant, Medical Health Officer at the St. Clair County Health Department. We will begin today with Sheriff King. Could you please discuss the role of the St. Clair County Sheriff's Office related to substance use?
Yes, hello. The St. Clair County Sheriff's Office, we have several hats in the game, or I'm sorry, in the realm of our battle of the opioid problem here in St. Clair County. Obviously, first and foremost, we're law enforcement. We're involved in a lot of other aspects such as treatment and education, and I'll talk about those things as well. But I'll circle back around several times to law enforcement because I think it's important to recognize that not just the sheriff's office, but law enforcement, if you will, all the police agencies in the county, and specifically our drug task force, we're the only faction that handles the law enforcement. There's many groups and many of the people here are going to talk today who work in conjunction with each other and with us to provide education and treatment and try to help the public understand what's going on and battle the opioid epidemic. But we are the only people who enforce the laws. So I'll talk about that mainly. I'll talk a little bit about some of the trends and then some of the programs we have in and out of our intervention detention center. So obviously the St. Clair County Sheriff's Office, we run the drug task force. So that is really one of the largest way that we battle the opioid epidemic. We target drug dealers. We try to find drug trends and get that education out to all the other law enforcement throughout the county and in the schools as well. We have several school resource officers and then again in all the other groups that we work hand in hand throughout the community. One of the trends that we're seeing in the drug world in and of itself is methamphetamine has really been up probably the last 5 years. Unfortunately, that doesn't mean that the opioid epidemic has gone away. We see a lot of opioid substances being used in different ways, right? Everybody thinks of opioids usually as either the prescribed pills or heroin. Heroin is obviously the drug that a lot of people overdose on. And unfortunately, the drug dealers are finding new and innovative ways to get different drugs out there. One of the big drugs we're finding mixed in with heroin or maybe even cocaine or sometimes even meth is fentanyl. Fentanyl is a synthetic opioid and it's very powerful. It's much stronger than heroin and it's easier for people in other countries to make. Typically in Mexico, along with your crystal methamphetamine, since it doesn't take a plant, there's no crop to harvest. It's chemically based opioid drug. They're turning towards that drug to either make their load of methamphetamine a bigger load so they make more money or just straight fentanyl. And we're finding people on the streets that are actually using straight fentanyl because they've worked up such a resistance to heroin. We find when we come across people who are overdosing on fentanyl that they usually take several doses of Narcan. And that's usually one of the first indicators to us when we're on scene with an overdosed person, that it's probably not just heroin, it's probably fentanyl laced or straight fentanyl. So that's one of the trends that we're seeing the opioid problem move towards. In 2020, I have some statistics, but our numbers were seemingly down a little bit because of COVID. We all know, the word nobody likes to use anymore, COVID-19, changed everything. And it also changed how we enforced laws. And we had to be careful, especially early on when we didn't have a lot of good information. And we started really targeting larger drug dealers, which we always do, of course, but we were being very selective in our enforcement. So in 2020, we only did 35 drug raids. Usually we do well over 100. That being said, we did seize 121 grams of heroin and 12 grams of fentanyl. The year before, 2019, we had much more enforcement, much more drug raids, but we had like 140 grams of heroin. So obviously more, but not that much more. One of the disturbing trends is the fact that we are running across addicts who are either addicted to heroin and they say they try methamphetamine to try to get off of heroin, or they're addicted to methamphetamine and they use heroin because methamphetamine will keep you awake for several days. Heroin obviously does the opposite, and they use heroin to finally go to sleep after being awake for 3 days, and they become addicted to heroin. So some disturbing trends there, as well as consistent prescribed opioid painkillers. Those are still being found to be a gateway into heroin and fentanyl. One of the other things we're finding is, fake prescribed pills. You may think you're getting a Xanax. People think they're buying a Xanax on the street and they take it and they overdose because it's actually compressed fentanyl. So we're seeing a lot of different, trends or different methods in which the drug dealers are introducing these drugs, sometimes to people who don't have any plans or even know they're getting into taking any kind of opioid. We have seen a good downtick in the amount of people who die from overdose. Good news is that the program with Narcan is working. We have Narcan obviously in all our EMS rigs, and as well as fire and police are carrying Narcan with them. We have Narcan in the jail. All our law enforcement officers have Narcan with them. And, we're able to Narcan people, get them the assistance at the hospital, which you still need to follow up at the hospital after being dosed with Narcan to take you out of that overdose. So that's saving lives. It's not stopping the drug use, but we always say if we can save a life, that gives that person one more chance to get to treatment. So good segue there into the treatment part. With law enforcement, I always talk about the fact that, again, we are the only part of the team here that enforces the laws. We also want to be involved in other things that involve treatment and ways for people to get off the drugs, right? We don't want to see the same people in our jail over and over. We don't want to see people continue to turn to crime to feed their addiction. But the bottom line is there are a lot of crimes that are caused by people who are feeding their addiction, and theft and robbery and things like that. So we still have to keep in mind the victims of those crimes. But that being said, we are involved in Hope Not Handcuffs, which is a program where an individual can come to our lobby 24 hours a day, 7 days a week, and just say, hey, I'm ready, I need some help. And a Hope Not Handcuff angel will come, make contact with that person and get them to some help right away, so they can get right into treatment without that gap in time, without people trying to change, or not trying to, unfortunately, changing their mind because of the addiction. And instead of it taking interdiction through criminal justice system, they can make those steps and we can be a safe place for them to come and find that help. We're also involved with Families Against Narcotics. I've gone to dozens of those meetings, very informative. If you're interested in finding out about how you can deal with a family member who is addicted to any drug really, but specifically opioids, it's a great group because you're going to be amongst people who are dealing with the same challenges you are. And then, of course, we have many programs inside our jail. Again, we always aim for the folks that come to our jail to leave better. It's our responsibility to give them the tools to grow and to not continue to relapse and make the same mistakes. We have a peer recovery coaching program. The peer recovery program helps the addicted people in our facility work through recovery, grieving, and through 12-step programs. We also have the RSAP program, which is a residential substance abuse treatment. The RSAT is an intensive program provided at our jail, and it is usually part of their sentencing. So if somebody was arrested and charged with crimes that include substance abuse, oftentimes they are ordered by the court to go through the RSAT program. And we're proud that 88% of the people who participate in that program in 2020 graduated. And that gives them tools to continue to be clean when they leave our facility. Obviously, in our facility, we have control over what's around and what's going on. Sooner or later, these folks are going to be reintroduced to our community. We want them to go out and succeed. We also have the MAT program, which is a medical assistant treatment program. That's a very important program because it puts together counseling, which is the program's contracted through Sacred Heart, as well as some options for medical assistance to get through their addictions, such as Suboxone, methadone, and Vivitrol. So those are some of the programs we have, and we're always trying to explore other programs. But again, I like to bring to light that we are the only law enforcement arm of the team, and we have to, unfortunately, sometimes take these addicted people to jail because they've committed crimes, may it be possession of that illegal substance or committing crimes that fed their addiction through, stealing things and selling them or robbing. And if we don't pay attention to those crimes, I think we lose light of the overall impact addiction has on society. And some people, the only way they're going to get clean, unfortunately, is if they're put in an environment where there are no drugs and they're shown other opportunities. So, in light of the time restraint I have, I could keep talking, but I wanted to lay out a good foundation as to some of the things that we do in law enforcement and here at the Sheriff's Office. And I'll pass the baton on and, of course, stay on for any questions later.
Thanks so much, Sheriff. And next up, we're going to have Jim Johnson from Region 10 PIHP. Jim, do you want to go ahead and talk a little bit about Region 10's role?
Sure. Thank you. Region 10, the prepaid inpatient health plan, or PIHP, our role is to fund and monitor a provider network that provides public behavioral health services, so public mental health services and public substance use disorder services. We contract with the state to manage that benefit for 4 counties, Genesee, Lapeer, Sanilac, and St. Clair County. So in that role, we have a number of funding streams that we manage, and we're responsible to do what we can to put a provider panel in place to treat all the substance use disorder and mental health needs of folks who are primarily on Medicaid or who are eligible for the public system. So when we talk about the folks who we would see, we have a significant crossover with the population that Sheriff King was talking about, but there are some significant differences. So, we'll see in St. Clair County somewhere around 1,000. We'll have about 1,000 admissions in a year for substance use disorder services. And what we've seen over the last few years from fiscal year 18 till now is that population is becoming increasingly male. And that's a regional trend as well as a county trend. So about, almost 60% of the folks that we see that we have admitted in St. Clair County over the past year were male, and regionally it's 62%. So by and large, the population that we see is shifting that way. We're also most likely to see folks who are between the ages of 26 and 39. So regionally about half, and in St. Clair County, it's up to about 55% of the folks that we see in treatment who get admitted are between the ages of 26 and 39, followed by folks between the age of 40 and 49, and then folks between the age of 50 and 64. It is fairly rare for us to admit someone who is 17 or under, or 65 or older. And, some of the primary reasons that we probably don't see a lot of those folks who are under 18, one is that oftentimes, substance use disorders can happen to anybody. It doesn't only happen to those folks who, who have limited resources. So a lot of times the kids that may come into contact with substances and develop problems may live in a family where they have private insurance. And so those folks would not come to us for their treatment. Or what happens oftentimes is those kids will be identified as having juvenile justice problems. And so they will enter the system through the court, and they may or may not be referred to us for treatment. So about 1%, and that's the number region-wide as well as the number in St. Clair County. So the folks that we tend to see are also most likely to have never been married. So as adults, we see folks who don't have a lot of resources. Primarily, that is our niche in the behavioral health community. So we'll see over 60% of the folks that we'll see have never been married. About 20% have been divorced, and right around 10% are actually married or cohabitating. So it's, if you're painting a picture of who's likely to be seen in the public system, that is part of it. We're also likely to see folks who are either unemployed or underemployed. So about 10%, 10 to 15% of the folks that we see in the public system are employed full-time. Almost a quarter of them are not in the workforce. We have under 10% that are employed part-time. And of course, it's about 60 to 65% of the folks that we see in our system are unemployed. So from a ethnic standpoint or from a cultural standpoint, region-wide, our numbers tend to mimic the population of Genesee County. Genesee is about 70% of our catchment population. So, we'll see about 75 to 80% of the folks that we see in treatment are white, and about 18 to 20% region-wide identify as Black or African American. And about 97% of the folks that we see in any given year fall into one of those two categories across the region. In St. Clair County, it's closer to 90% white and 7 to 9% who have identified themselves as Black or African American, and that is about 96 to 98% of the folks that we see identify as one or the other. So, given the demographics, there's probably a slight overrepresentation of folks who are Black or African American in our treatment population, because it's, I think, under 3% in St. Clair County from the total population standpoint. In terms of the types of substances that people are using, their primary substance at the point of admission, we're seeing the alcohol is increasing. The number of folks with alcohol as their primary drug of choice, and it's at 40% or higher. So the folks that come into care through us, it's up to 40% region-wide and 42% in St. Clair County. We've actually seen a reduction in folks who have identified heroin as their drug of choice, down to about 24% region-wide and 23% in St. Clair County. Cocaine is on a slight uptick in St. Clair County. I don't know, Matt, if you see that too, but up to about 8% of the folks that we see, just a slight increase, from 5-6% to 8% of the folks we see identify cocaine. Other opiates, around 10%. And then as marijuana has actually decreased. Some of that probably due to the fact that it is legal, so less people are being kind of forced into treatment for use of marijuana. And the big increase region-wide and in St. Clair County, as Matt alluded to, is folks who are identifying methamphetamines as their primary drug of choice. It's up to about 8% region-wide. It used to be about 2-3%, and it's about 11% in St. Clair County, and it used to be about 5% of folks who would identify that as their drug of choice. So again, we have a very small number of people who, under 10% of the folks that we see would have kids, dependent children. About 4% pregnant. 4% of the people the women who come into treatment are pregnant, which is a small percentage, but as I'm sure Dr. Merkin can tell you, is way too large a number when you consider the risks that we're putting those kids through. So the The bigger issue that we're starting to see now, though, across our system, and we're starting to track it, I think we've always seen it, is the number of folks who don't get into treatment or who don't stay in treatment. So you can only do so much, as a referral source or as a provider. But one of the things that we're seeing across the last couple fiscal years is about almost 20% of the people who come through our access center and are deemed eligible for services never make it to a provider. So somewhere between that point of being determined eligible and that first appointment, something happens and they never make it. And usually that first appointment is within a small number of days. We have 14 days, but usually our provider network is very good at getting that in under a week. So about 20% across the region don't make it to that first appointment. And then what we see once folks get into treatment is we have a lot of folks who, we don't have a lot of folks who complete treatment. So when people leave, our providers document why they left, or, in a kind of a general sense. And what we see overall across the region is about 40% of the people are completing treatment, leaving according to plan. And that's up to about 45% in St. Clair County. And about 48% region-wide drop out of treatment. So they just leave treatment before goals are completed, before there's been any sort of agreement or acknowledgement between they and their provider that it's time to move on to some other ways to foster your recovery. And that's about 43% in St. Clair County. It varies a little bit based on the type of substance folks are using when they come in. We seem to do better at keeping people in treatment who are using alcohol. For instance, about over half of those folks complete according to plan in St. Clair County. We don't do as well with heroin. We're about half of the folks who come into treatment identifying heroin as a drug of choice drop out of treatment before it's completed. And that's true with other opiates as well. So one of the things that we're starting to do is to develop reports that will show us that in more a real-time sense, and show us that by county, by provider, by drug of choice, by race, and to be able to put that information out so that providers can use it and we can really work on engagement. And that's probably the key term that we're throwing around at the PHP is really need to kind of focus in on how we engage people at the front end and keep folks engaged in treatment until they have a somewhat stronger handle on their own recovery. So I will leave it at that, Sarah, and let you pass it on to whoever's next.
Thank you so much, Jim. Deb Johnson, you're up next to talk about the role of CMH.
Okay, well, at St. Clair County Community Mental Health, our role with substance use disorder is threefold, or we wear three hats. We have a role in treatment, prevention, and in community collaboration. On the treatment side, we provide services for substance use disorder with or without an existing mental health diagnosis. And that's kind of newer for us in the last couple of years. Prior to us becoming what's called a Certified Community Behavioral Health Clinic, or CCBHC, we could only provide substance use treatment for people who had dual disorder, meaning a mental illness and a substance use disorder. But now, because of the change in our funding, we can provide services to anybody who has a substance use disorder with any type of insurance or no insurance at all. So, so that's a big change and has really opened up access. A big component of our philosophy as an organization is the recovery model. And the recovery model emphasizes a person's potential to improve and live well. It's more than just surviving an illness. Here at CMH, we believe that recovery is not only possible, but is to be expected with good treatment and support. Recovery is an active movement that brings real life changes in lifestyle and habits, and it means living the life the person chooses to lead. We utilize peer support specialists to help people in recovery because we know that connecting somebody with a person who has lived experience, someone who has been where they're at, contributes greatly to engagement and to the person's recovery journey. You have heard, I think, throughout this webinar from some excellent peer support specialists. I think it was in the beginning of the webinar series. They were, we're happy that they were generous enough to share their stories with us. And, we have lots of peers, as I said, working here who have been in recovery for a long time. So So again, we know it's not just possible, but it should be expected with good treatment. We offer a lot of evidence, a lot of different programs to treat substance use disorder, including several evidence-based practices. One of them is IDDT, which I was just talking about before. It's integrated dual disorder treatment, and that's for people who have a mental illness and a substance use disorder, which was the only people we could serve. So that's our longest evidence-based treatment, actually. But now, obviously, we can take people without dual disorder. But anyways, it is a treatment team that will come together to help support a person, meeting them where they're at. And it's a mix of different service providers, clinicians, case managers, and peers. We also use an adolescent community reinforcement approach, which increases the family's social, educational, and vocational support system of an adolescent to support the recovery from substance use disorder. We also provide medication-assisted treatment. Some of you may have heard Dr. Saeed this morning, our medical director, touching on this. Medication-assisted treatment, when combined with therapy, is an incredibly effective solution for people with substance use disorders, and it definitely offers great outcomes for long-term recovery. We also have teams that work with individuals in both recovery court and mental health court. So those programs are obviously in collaboration with our criminal justice system. And those programs are designed to help people move forward and pass their barriers and hopefully reduce recidivism. Motivational interviewing and motivational enhancement training is provided, and that is a technique that explores a person's motivation to make changes. We also have a mobile crisis unit that's been in place for a number of years now, and the mobile crisis unit is available 24/7, and they are able to meet a person in their moment of crisis anywhere in the community, 24 hours a day, 7 days a week, and link them to supports and resources. We also know that people with a history of trauma have a greater risk of developing substance use disorder. So all of our clinical staff are trained in trauma-informed care. We offer trauma-sensitive yoga, other trauma-focused modalities, which are intended to augment a person's treatment. We have a lot of highly trained staff, many of whom hold certifications through the Board of Addiction professionals, in addition to other professional licensures. However, I'll use this as a quick infomercial or commercial. We're always looking for more staff that are, have the proper training credentials. We can provide some of the training, but we need master's level clinicians. We have great incentives right now, and we pay a really good salary along with great benefits. So if you know anybody out there and that's looking for a new job or just work more hours, we'll do part-time too. We could use them. So let's see, all the things that we talked about come from a strength-based approach. One that focuses on a person's skills and positive attributes with the underlying message that recovery happens. We talk about that all the time. Another guiding principle of the way we operate here at CMH is with our focus on integrated healthcare. And integrated healthcare means focusing on the whole health wellness, seeing and treating the whole person, treating them as a whole person and not just a series of separate diagnoses. We say often you can't just treat the brain or just the body. It's connected, so you need to provide good whole health treatment. So the integrated part, integrated health, means that we're not just addressing the behavioral conditions, as I said, like mental illness or substance use, but we're also addressing physical conditions like diabetes, high blood pressure, obesity, chronic pain, etc. Our major provider to help us do this is the People's Clinic. They're located, I shouldn't say that they're the only major, because the other major one is the health department. But the People's Clinic is located inside our building here in Port Huron. And we have an integrated electronic health record that we share with them. So all the care providers can see information on both the physical and the mental health treatment of individuals, their meds, all those kinds of things, and can check and make sure that all the needs are being met. Our treatment teams through this process bring together both People's Clinic staff, CMH staff to meet and review records and ensure that all providers are on the same page when it comes to people's treatment. We also, for people who, there's a lot of people, some people that come to us that do have a primary care in the community, and that's great. And we encourage them to keep that doctor, but we ask them to sign a coordination of care agreement so that we can exchange information on a regular basis with their provider so that we know about any important health issues, medications, etc., and can help provide whatever support they need to continue to focus on whole health improvement. We also know that it can be very challenging and overwhelming to manage multiple health conditions. So our goal is to support people every step of the way. On the prevention side of things, we have an emphasis on community education and outreach and strive to be the local clearinghouse of information related to behavioral health. Some examples that I'd like to highlight include community events. Like we attend a lot of health fairs. We do speaking engagements whenever we're asked to talk about services, including prevention. And we also put on a lot of trainings for both the community and other professionals, including this webinar series. We participate and actually provide mental health first aid training. It's a free 8-hour training that any adult that live or work in St. Clair County can take for free. It uses role playing and simulations to demonstrate how to offer support in a mental health crisis. So just like CPR is for first aid, in a physical health emergency, mental health is the first aid that prepares people to interact with a person in crisis and connect them with the help that they need. We also use the media a lot. We operate a comprehensive website that provides not only detailed information about our services and how to access them, but also includes information on behavioral health, advocacy, integrated healthcare, and on any events that we host throughout the year. So you can find that at sccmh.org. We also have an active Facebook page, Instagram, LinkedIn. We have a YouTube channel that, if you heard at the beginning of this, all the webinar sessions from this series have been recorded and will be uploaded to the site. So if you know of somebody who missed it or you want to have them share this with them, please do that. We also routinely have articles and opinion pieces that go in the local news, highlight important topics, events, as well as regular radio and interviews on EBW TV, CTV in St. Clair, and of course the Paul Miller Show in the morning. So now I'd like to wrap things up by talking about collaboration. We know that no one agency can own the opioid crisis or substance use disorder in general in any given community. Each of us has an important role to play. It is, it's a community problem and crisis, and it takes all of us to continue to work to address it. A great example, before I give you the example, I want to talk about our long history of playing an integral part in a community service coordinating body. Everybody sitting on the panel are all part of that. The CSCB, we like to call it because we love acronyms. But the CSCB goes back over 35 years. And the group is a network of businesses and nonprofits we have a bunch of work groups that tackle different social issues in St. Clair County, everything from hunger, homelessness, substance use disorder, early childhood education, elder abuse, all those sorts of things. And we operate with the guiding principle that community-wide issues are best addressed with community-wide solutions. So a great example of the collaboration, again, is this recovery summit that we're wrapping up today with our panel discussion. The series was a collaborative effort between CMH and the treatment subcommittee, which is a committee under the CSCB. So with that, I think that's about all I want to say for now. Thanks.
All right, and we are going to pass it over to Ken Huvelman from Odyssey House. He's also a member of that treatment subcommittee that Deb was just talking about.
Oh, can I say one more thing, Sarah?
Sure.
There's questions that are coming in. Are we going to do them at the end? It's
yeah, we're going to, yes, we'll do that at the end. Yep.
Okay. All right. Thanks.
Okay, so yes, my name is Ken Huvelman. I work with Port Huron Odyssey House. We are an outpatient treatment center and recovery housing provider here in the community. I also do co-chair the SUD treatment and recovery subcommittee through that CSCB that Deb just mentioned. Some of the things that we've identified that we're working on here within the community, organizationally, we were provided grant funding through the state of Michigan to create what we call MORT, which is the Mobile Overdose Response Team. This is a collaborative through the state of Michigan's initiative known as MODA, again, acronyms, the Moving Overdose Data to Action. So we've spent lots of time as a state collecting surveillance and data to determine what's happening. The next steps is taking those numbers and putting them to work. The MORT program is something that was built out of this. It involves our peer recovery coaches, SUD counselors, and then we partner for that with the Port Huron Police Department, Community Resource Officer and Detective Dwayne Hunger, who also presented at this summit, is our common officer that we work with. 72 hours post overdose, we will have a police officer and a recovery coach approaching the individual's home. So where that person overdosed, where that person lives, within 3 days, our goal is to have someone with a recovery focus to provide screening, brief intervention, referrals to treatment. Part of that is we also do provide them with recovery resources. It's a quick packet with information to get connected to CMH, to ourselves as a provider for Sacred Heart, for Meridian, for FAN, for Blue Water Recovery Outreach Center, BW Rock. It is that part where it's not about us, it's about the individual who's experienced that overdose. And to help a village, we need to help the members of it. One of the things we've been able to see with this is we've been able to recognize trends, patterns, and things. Some of the information that Sheriff King talked about, such as identifying pressed pills, that is something we recognized out of the MORT program as well. We had multiple individuals overdosing on the same type of object or pill. We're able to identify through open conversation what was going on there. With these trends, I recently looked at the Drug Task Force arrest records that were just released by the Sheriff's Department. Those, if I overlap those with the overdoses within the city of Port Huron, the same neighborhoods, the same districts, the same areas are where the arrests and the overdoses are happening. So that helps us recognize where to better focus services like harm reduction through the exchange, which is the syringe service program provided by the health department. So it's identifying ways to get harm reduction tools to individuals. It's a way to recognize how to get the conversation of how do you start recovery happening with the individual in that what's known as a recovery window. Statistics say that a person dies, I think 50% of fatal overdoses are within 1 month of a previous overdose. So getting to someone within a month can cut overdoses significantly. Getting to them within 48 hours is another significant drop in potential fatal overdose. I'd love to sit here and say that within the city of Port Huron, we've recognized that things are getting better. That would be a lie. Given this year alone, at this time, as of today, we've had 102 overdoses within inside the city of Port Huron. Last year, as a total, we had 106. So with 3 full months of the year left, we are at basically the same amount of overdoses we've had. Of that, 11 of those overdoses have been fatal. Our goal is to reduce the number of overdoses and truly reduce the number of fatal overdoses within the city. And these are the ones identified through this MORT program. Kind of like Jim Johnson had mentioned, we are looking at overwhelmingly male. It's about a 60-40 split, where it is men overdosing more frequently than women, with an average age of overdose for the city of 35. Other parts of that is we do see those trends going in that direction. Sheriff King mentioned that methamphetamine use is on the rise. That is one of our other higher notes. St. Clair County is not in the right spot for methamphetamine use. It is increasing. Additionally, what has been interesting, and this goes into the world of harm reduction, to provide items like fentanyl test kits to make sure drugs don't contain fentanyl. There's a project by the state known as STORM. I'm probably butchering this acronym, but I believe it's Swift Toxicology for Opioid-Related Mortality. 38 counties are part of this, and they recognized that 60%, that's 60% of methamphetamine fatal overdoses contain fentanyl. The question was this: is this a person using multiple substances, or is this due to methamphetamine laced with fentanyl? There is situations where cocaine is becoming laced with fentanyl, creating spikes in overdoses in counties across the state. So it's really using some of this information that is just tracked to find a way to get help to the person. Waiting for an individual in addiction or a person trying to find recovery to come to us is one way, but we identify that we're missing a lot of people. So kind of that gap that Jim mentioned, where people will make the phone call for treatment, but they won't make the drive to the office. So how do we capture that population that said, I need help, and then maybe changed their mind or addiction pushed over? So the MORT program has really been helping to navigate how we can reduce that gap. We do provide naloxone. It visits, if it's the person, if it's the family member, if it's the neighbors that see us there and want naloxone, we will provide it. Port Huron Odyssey House is also a group naloxone provider. So if you need a training for an organization, we've done them at apartment complexes. We have them scheduled for hotels. We've done them at the shelters. The goal is to get those life-saving naloxone kits into the hands of people at risk. Sheriff King mentioned that there's been an increase in the number of doses necessary. Earlier this year, the FDA did approve to increase the dosage in those standalone or leave behind kits. So the kits you can pick up from a pharmacy, health department, and other places will soon be twice as potent because many people are going through 2 to 4 kits just trying to resuscitate someone experiencing an overdose. So that's some of the news that's probably less than exciting, that we're seeing negative increases in situations for. But the MORT program is designed to push us towards. In the world of treatment and recovery, what we've been working on as a CSCB subcommittee is advocacy for the expansion of MAT, or medication-assisted treatment, here in St. Clair County. We have a few providers, but some of those providers may have difficulty getting to. Some of the providers are capacity. So there's been advocacy to expand accessibility to MAT. That would include Suboxone, Vivitrol, and Methadone. Some of the other things that have happened is we are working to identify gaps and increase access to treatment for adolescents. There has been a recognition that adolescent services is not as strong as it is for adults. So waiting for our kids to spiral into a life of drugs and alcohol, we would like to work to get to them sooner, especially peer-led groups where kids are able to support each other. One of the exciting things that has come from this is a recovery high school that is opening this fall for individuals identified as having an SUD and being in the school age from 6 to 12. Additionally, we have recovery community organizations like BW Rock that have started providing traditional and then holistic alternatives for recovery options. And it does sound like the 12-step community in-person meetings have come back. So there are steps to address the increases and concerns we're seeing. With that, I will defer over to Dr. Mercantile.
Thanks, Ken. All right, Dr. Mercantile.
All right. Hi. Well, I don't have quite as much to say, so I'll just kind of start out by saying I think the health department was quite honestly in the lead of this 10 or probably even 15 years ago. When we did health assessments, we recognized that at that time, prescription opiate use was really out of control. And through our collaborative efforts, I think there's been a great deal of activity. So hands off to all of our community partners. We do consider ourselves kind of community health strategists, and with our every 5 years doing a comprehensive health assessment is often where we get those inklings of problems. So we will continue to convene with health data, hopefully being able to expand our epidemiology section and our data support. We've been pretty preoccupied with COVID last couple of years. That's pretty much the only kind of data we've been working on, but we're anxious to get back to this work and work with our partners. The other piece, of course, is prevention, and we've been always this kind of the key component of public health is to identify what parts of health, either health delivery, and actually there's things called social determinants of health, so non-health care delivery aspects that are contributing to poor health outcomes. And some of this really points to prevention. So as Ken mentioned, about 2018, we identified the increased risk with IV drug use and infectious diseases, and a very strong evidence base for syringe service programs to reduce this problem, as well as to open up the opportunity of access to that population. We started our program in 2019, and to date we have provided, I don't have the total, but for the calendar year 19, we distributed over 2,500 syringes. The good news is over a third of those syringes are returned. I know there was some community concern, is like, we're putting all these extra syringes out there, does it increase the environmental risk of used syringes? And the answer is, the data is pretty solid with this. It actually reduces the risk of accidental syringe pokes and such of that, because we're providing resources for people to return them. And I think that's what we're seeing as well. But the most important thing is when people come in for services for syringes, they're also provided screenings for bloodborne infections, particularly hepatitis C and HIV. And those programs have been going strong. For 2020, we did over 400 hepatitis C testings, and HIV, we do about 700 a year. A little impact in 2020 with COVID, but the idea is to continue to provide concomitant services. So you draw in with a syringe service, which, by the way, quite honestly, is just giving people sterile equipment to use for their drug use, which reduces the risk of all of these other concomitant problems. And this is, like I said, doesn't encourage, and a lot of people say, well, this will encourage drug use. It does not encourage drug use. It allows drug users to begin that journey towards recovery, because we know recovery is a continuum. Everything from chronic use and destructive use, careless use, all the way to complete sobriety and prolonged sobriety. And in between, there's a huge range of opportunities that these services provide. So that's our secondary prevention tool. And I think even despite the COVID, we successfully launched this year our mobile unit, which is a handy dandy little van that we get all these services tucked into. And thanks to the Odyssey House, we are now in several locations and looking to expand. We're also looking to include a recovery coach on our mobile units. So again, that opportunity isn't missed when somebody shows up to receive our services. And I think that's all I have to say right now. Got my list out, but I hate boring people with numbers, but the idea is to find the gaps and find the resources to fill those gaps, whether it is us as a health department or finding our community partners to help us do that. So thank you to all my community partners out there.
Excellent. Thank you, Dr. Mercantile. So now we are at the Q&A portion of our panel discussion. So if you have questions, go ahead and put those in the chat. We have a few in there, and then we have a few that were submitted ahead of time. So our first question, this will be for CMH in Region 10, so Deb and Jim. Could you discuss any recent or proposed policy changes that could have an effect on our current mental health, behavioral health system that does include substance use disorder treatment?
Did you want to go first, Jim? Or do you want
Go ahead.
me?
Go ahead.
I was just going to say, the biggest thing happening out there right now is the attempt to privatize the public behavioral health system for the state of Michigan. And so there are these two Senate bills that people, and there's actually a House bill too. And maybe Jim knows the House bill. I know it's the Whiteford bill, but I don't know the number of it or if it even has a number yet. The Senate bills are 597 and 598. I guess in a nutshell, they what they propose to do is to integrate, they think it's going to improve and create better integrated care, but all they are proposing basically to do is integrate the funding at the state level. And then give it out probably to a Medicaid health plan and manage. We're very concerned about that because the Medicaid health plans have had the benefit to provide 20 outpatient visits to mild moderate population for the last 20 years and haven't done a good job at all. Less than 4% of the, or well, actually less than 10%, I guess, of the people that sought the mental health services from them got them. It's not good. And so there's nothing that would lead us to believe that they do a better job with the more severe population in substance use treatment. So, so that's a big concern. Actually, the sheriff and I just testified this past Tuesday at a Senate Government Ops Committee meeting. It was really interesting to say the least. We were up there and they asked us a lot of questions for about a half hour we sat up there. I think we did pretty good answering. The sheriff did a great job too, advocating on the behalf to keep it public. I mean, this is the public safety net for our community's most vulnerable people, whether it's mental illness, substance use disorder, or intellectual developmental disabilities. So it's very important that we continue to watch this legislation and continue to advocate. Right now, we have there is a request for action out to anybody. We have an action alert on our Facebook page. I think it's on Instagram and LinkedIn and our Facebook. And we send it to all of our CSCB partners, asking them to share it with all of their staff. And it's super easy. You just click into the link. If you want to add any specifics, you can do that. If you want more information on any of that from us, we're happy to provide it. We're going to put together another little package as a result of some of the questions we were asked when we were there on Tuesday, and send it to the senators. One interesting thing, and I wish I would have done this well before the Tuesday testimony, but I looked at my testimony from 2016 when they tried to privatize the system back then, and it wasn't very much different. And also as a result of that, they put together a statewide work group with all key stakeholders, came up with these should be the final version. I have this thing that came out from the department, final version of the core principles and values that our system redesign should be based on. But I guess they forgot about that because now they're the Senator Shirkey is introducing these that doesn't even take any of that into consideration. So that's all. And then there's the Whiteford proposal, but Jim, do you want to talk more about any of that?
Well, not especially. I mean, both of the proposals really do tend to just integrate things at the funding level. And as anybody knows, when you have any sort of medical issue, whether it's behavioral health or physical health, and you need something from more than one type of provider, you don't call your insurance company about it. You talk to your provider about it. You talk to your doctor, you talk to your counselor, and develop a plan with them for how to best address it, and then look for the insurance company to pay for it. And so the whole plan, it's really backwards to think that an insurance company should be reaching out and telling your providers how to best integrate your care. That's not how the world works. On the positive side, one policy development that we're hoping to see, some of the relaxation in the policies that have allowed for more telehealth services during the COVID pandemic. We're hopeful that some of those, the relaxation of some of those policies will become permanent. As it stands, they look to expire sometime this next calendar year. But we're hopeful that for folks who actually, work better in that kind of model, that option will remain open to them.
I know if the sheriff had anything to add, I don't know.
No, I think you covered it. We work together as a group, and as I expressed my feelings yesterday Tuesday at the hearing, to splinter the amount of people who are in control, or I shouldn't say in control, but providing the services is going to further complicate the ability to work as a community. I can't imagine, I know who I need to reach out with to when I need to talk to somebody from the community mental health system, and it's Deb Johnson or Jim Johnson or Karen Zoltak or several other people I know. And you throw another 24 hats in there, it's really concerning. People coming and going as the income is good or bad for them, and the patient relapse or missing the connecting of the dots of the needs of the community. I could go on, but I'm really concerned about it. We have a good thing going here in St. Clair County, And I sure would hate to see a disruption of that because of people's other motivations. I'll leave it at that.
I guess I want to add just one last thing on it. Maybe an easy way for everybody to understand it too, when they're talking to people is the model takes, and there would not be a PHP, there would not be a Region 10, there would be one state's SIP. And one of the senators asked me how we thought that would work. And I said, I don't think it's going to work, because can you imagine calling up this one state entity so if you have a problem with St. Clair County CMH, right now, you can call Region 10. You're going to get a human voice. You can talk to somebody about what's going on, or any of the other contractor providers in our community, or for that matter, in our region. But if you call this big entity in the sky, and it's going to be big because it has to oversee the entire state of Michigan, all the CMHs, all the other providers, SUD including. So I just can't imagine how that's going to be better. And those are the people that would do care coordination as well. In terms of access to services and anything else. So now in our community, somebody will call me and say, hey, so-and-so just try to get into services, and they had an issue. Can you help out? Yes, I can help out, because I can call access and I can give either the person's name or find out what happened. If it's that other system, that will all be out of our control. So we really lose local control and local governance. And I think our community's done really well with having local control and governments. And I would hate to see that taken away, because it's going to hurt, again, the most vulnerable people in our community. That's my final word for today.
Okay. All right. We had a question. Sheriff King, you talked about the Hope Not Handcuffs program. Is there a sense or a number? Do you keep statistics? How many people are utilizing that as kind of their entry point to recovery?
I don't have exact numbers. I know they're unfortunately quite low, to be honest with you. I want to say last year, or the year before, I think maybe 6. But the possibility of getting help without worrying about getting in trouble or waiting till you get in trouble is there. We're not the only facility. I believe Port Huron Police and Clay Township Police Department do it as well. And there's probably more, and I apologize if I'm forgetting other police agencies, but the program's there, and I don't know if it's the nature of the addiction, because it really takes that person the decision to go get help, and it's an outlet for them, or if it's a lack of getting the word out, or both. But the numbers aren't huge, but it's a program we're dedicated to.
And then Jim had talked a little bit about folks eligible for treatment but not getting treatment, something like 20% of people eligible not receiving treatment. And Ken, you had talked a little bit about the mobile overdose response team as something that could help fill that gap. What are other things that, from your perspective, could be done to help fill that gap of people eligible for treatment but not making it to treatment?
So,
Go ahead, Ken.
sorry. So it's identifying some of those and finding ways to connect that linkage of care. I think that getting out and being able to get to them and eliminating those barriers that are identified. It was mentioned policy for telehealth. Telehealth has eliminated the barrier of transportation, childcare, and taking time off employment. So that's helped us see people get into treatment. But I think it's being able to get a person to help them navigate that short wait time. And as Jim Johnson mentioned, we do have a fairly short wait time in St. Clair County compared to others. So it's just really working to keep that person engaged. The mobile overdose response team is designed to be a linkage to care tool to provide that transportation to residential treatment, to provide that transportation to any services necessary. So to work to get out into the community to be more of that through community coaching, through case management, through whatever ways we can get people connected to that person that cares. It shows, it helps people buy in a little more.
I'll make a comment about that too. I just want to, my 2 cents a little bit. We actually did some focus groups on pregnant women and substance abuse and found that really, besides childcare and transportation, which Ken mentioned, stigma is a pretty significant barrier. Particularly, we found stigma from their healthcare providers. So as a result of that, we have engaged many of our local healthcare providers in substance use treatment, or excuse me, training. The summit that Deb Johnson talked about, we utilized some of our connections with the medical society, offer CME so that our doctors participated. And I think those kinds of approaches as well, I think are very MAT, making people think of substance use disorder not just as a dysfunctional attitude or behavior, but as a true medical condition, which we know it is. So I'll just say that I think stigma is a major component as well that really can only be addressed at a community level.
And we're looking at things, when we talk about 20% of the people not making it from the point of eligibility determination to their first appointment, we've been looking at some different grant funding to actually use more peers to do outreach to folks after they've been determined eligible and a referral's been made, to kind of stay connected with them and to battle that ambivalence that almost everybody has when they call and ask for treatment. On the SUD side, I think it's even stronger, and the longer you wait to have that next contact, the more likely it is you won't have it. So we are looking at the potential for engaging folks in recovery to help folks stay engaged even to that first appointment.
All right, so we're about at the end. I do want to take the one last question we have here in the chat. Deb, you had talked about trauma-sensitive yoga, and someone was wondering how they would access trauma-sensitive yoga.
I thought it was a two-part question. We advertise all of our programs on our Facebook under events and also on our website. I assume is that events tab too, Sarah?
Yes.
But also, we're going to be doing another virtual yoga class coming up soon, so anybody could participate that from anywhere. But you just have to click into it. But when we start doing the in-person ones, it will be for primarily St. Clair County residents. But the virtual stuff is open to anybody. So check the website or the Facebook events. And if you have any trouble with that, you can give us a call. You can call me, you can call Sarah at 985-8900, 810.
Yeah, and the yoga class, the virtual one coming up, is under free classes on our website. So if you look under the free classes tab, that's where it'll be. So we have definitely reached the end here of our time today, and I know that we probably could have gone on so much longer. We have excellent minds here on this panel today. So I want to thank everyone for joining us today and sharing this information on this important topic that deeply impacts our community. So this concludes our Recovery Summit virtual series, and I just want to thank everyone who's tuned in so far and participated with us. As a reminder, you can find materials and resources related to this series at sccmh.org, and recordings of each of these sessions will be on our CMH YouTube channel. And a reminder for any of our attendees who applied for continuing ed credits, you will receive your certificate via email, the one you registered with, over the next few weeks, and it will include each session that you attended. So thanks again, everyone, and we will see you next time.
See ya.